Hi, I'm Dr. Donald Jurovich, Professor of Geriatrics at University of North Dakota. Today, we'd like to talk about dizziness. And our objectives are to describe why dizziness occurs in older adults. I'd like to talk about the evaluation of older adults with dizziness and syncope, and then its treatment. Topics covered include classification and causes of dizziness, as well as the evaluation and management of dizziness in older adults. So the importance and complexity of dizziness is most importantly that it's a common condition in older adults. Various prevalence and epidemiologic studies suggest that the occurrence of dizziness is from 4 to 30%. It certainly increases with age, and women tend to be affected more than men, and oftentimes, as we will see, it's multifactorial. So there's a lot of challenges related to dizziness. The precise classification is often elusive. Specific therapies, such as antivert or meclizine, are not always working very well. And so there's not many specific therapies and really not a lot of research either that's moving ahead with treatment of dizziness. And then the other problem is that most of the cases in older adults have multifactorial etiologies. So I'd like to really divide or think about dizziness in terms of an acute episode versus chronic. And so the acute dizziness is independent of age generally. It usually results as a disorder from one system as opposed to the chronic condition, which is multifactorial. And some of the more common causes of acute dizziness include acute vestibular neuritis, cerebral vascular ischemia, and various cardiovascular disorders that often result in hypotension. By contrast, chronic dizziness is something that usually occurs for greater than 1 to 2 months. It is more age-specific, being more common in older adults. It has multifactorial etiologies, and it's really more or less considered a geriatric syndrome. And it takes a multifactorial approach and to focus also on medication side effects as an underlying etiology. But chronic dizziness really has some considerable consequences. It's associated with increased fear of falling. It can be associated with depressive symptoms, fall risk, and just general decline in functional ability. So the important point is that vertigo is never continuous. It's there is, even with structural lesions, adaptation and habituation, which can occur in weeks. And so if you have somebody that considers their dizziness or vertigo as persistent, ongoing, unrelenting, generally that has a psychogenic underpinning. So that's an important distinction. And just also to mention the fact that there are adaptive processes in habituation, you can use that actually as part of your treatment intervention, where you try to reproduce the positions that induce vertigo under obviously more controlled conditions. You don't want to be flying an airplane when you're doing habituation therapy for benign positional vertigo or other types of dizziness. But the point is that if you can find a certain position that causes the dizziness, that recurrent positioning will help reduce the symptoms of vertigo and dizziness. So if we try to classify dizziness according to symptoms, we have true vertigo. So this is considered to be episodic spinning or a rotational motion where either the person or the environment rotates. It could be either or. By contrast, there's presyncopal episodes where you have this sensation of you're going to faint or you feel lightheaded, and those are often the words that people describe. There's a disequilibrium syndrome where you feel off balance either when you stand or walking, and sometimes presyncope and disequilibrium can cross over. So if somebody gets up out of bed and they say, oh, I felt light in the head, but then I felt like I was going to fall back, then we have to sort out which is which, and we'll talk about things like orthostatic blood pressure check as one of those mechanisms for evaluating the differences between presyncope and disequilibrium. And there's somewhat of a catch-all term of all other forms of dizziness. These include the more vague feelings such as floating, again, lightheadedness may be used to describe that, or wooziness, and other nonspecific sensations. A mixed dizziness syndrome would be a combination of two or more of the above, and that actually is the most common type. So that's why it's such a challenge to deal with dizziness. So in terms of vestibular specific disorders, include benign paroxysmal positional vertigo, Meniere's disease, idiopathic recurrent vestibulopathy, acoustic neuroma, and cerebral vascular disease. So it turns out that the absence of spinning sensation does not automatically exclude vestibular disorders, because patients with actual vestibular disorders might describe their problem as more of an imbalance or a disequilibrium or other sensation. So that's why we have to go through a somewhat structured physical exam and figure out what the underlying pathophysiology is of the dizziness sensation. So in terms of benign positional vertigo, it most often presents as an episodic. It'll occur with change in head position. So if somebody's in bed rolling over, or if they gaze up at the sky or look down, those can all be precipitating moments. They can be sudden, generally seconds-long bouts of vertigo. And most likely they result from a dislodging of otoliths in the semicircular canal. And you can see on the diagram to the right a stained cross-section of the semicircular canal with little dark stones there circled in red that are otoliths. So here we have Meniere's disease, and for those who are wondering what he looked like, there he is in person. From the 1800s, he was I don't know if he was a protege or an associate with Dupuytren, another French physician of fame for Dupuytren's contractures. But Meniere never really reached full professorship, as was his career goal, and he, I guess in some respects, was banished to a deaf-mute institute where he wound up describing a disease that's named after him. So it's considered idiopathic. Meniere's disease has repeated episodes of tinnitus or ringing in the ears. There might be fluctuating hearing loss with a sensation of fullness in the inner ear, and it can be associated with pretty severe vertigo. Turning towards non-vestibular issues is presyncope. This is a sensation of faintness or lightheadedness. It often is associated with decreased cerebral perfusion and is precipitated by postural changes, such as getting dizzy on a stand to up from supine position. And it may occur with or without measurable orthostatic hypotension. Also common in frail, diminutive, older women, typically frail, again, older adults, is postprandial hypotension. And you can see in the diagram here, in this graph, that there was a large caloric challenge provided to patients, and you can see the immediate drop here in the blue of the systolic blood pressure. Not so much with the diastolic, a little bit, but primarily in the systolic blood pressure. And you can see that it occurs within 30 minutes. There tends to be a little waffling after the first hour, but then there's a persistence after 2 hours. So the take-home message is that if you ever request orthostatic blood pressure checks on older adults postprandially to rule in or rule out this condition, it's important to do it within 30 minutes of eating or an hour to 2 hours after eating. So disequilibrium is another condition of dizziness that we need to talk about. It's a sensation of imbalance or unsteadiness. Here, there's many factors that contribute to imbalance, sometimes vision problems, proprioceptive disorders, particularly as we see in paresthesias with diabetics, also in musculoskeletal disorders, as well as various gait disorders, such as you might see with normal pressure hydrocephalus, where you have that antaxic, wobbly, drunken sailor-like gait. And I just want to bring your attention to this picture about bifocal lenses or progressive lenses. Really, one of the more evidence-based findings recently has been for older adults that fall is that they should wear distance glasses alone while walking and not to use bifocal or progressive lenses because of the blurriness occurs that when they look down during the fall, they can't really compensate very well. So sort of the catch-all for dizziness are the other forms. And again, the patient may describe a variety of symptomatology. A lot of times there's a psychiatric cause that can be associated with depression and anxiety. And also mixed forms of dizziness. So those basically are a combination of two other forms of dizziness, such as hypotension or disequilibrium. This is the most common type reported by older adults. And it may be a combination of etiologies that involve some vestibular components, some central nervous system components, and visual or proprioceptive problems. They often are accompanied with systemic disorders, multiple medications. And then finally, you need to consider carotid sinus hypersensitivity syndrome as part of this differential diagnosis for this mixed dizziness condition. So some of the culprits for dizziness are, as you might imagine, medications. These include anxiolytics, antihypertensives, particularly loop diuretics, antidepressants and antipsychotics, well known as the ototoxicity of aminoglycosides, high-dose nonsteroidal anti-inflammatories, often associated with tinnitus, as well as antihistamines and the infamous anticholinergics. So some of the characteristics of dizziness in older adults is that when it occurs, it usually will resolve within days to several months. It can be chronic or recurrent. Again, it has multifactorial etiology. A lot of times it'll be associated with postural hypotension, and in one study, presyncope or syncope actually was found to be associated 25% of the time with postural hypotension. But also, many times the older adult will have anxiety or depression that accompanies the dizziness. And certainly the use of 5 or more medications, which by definition is polypharmacy, is also associated with dizziness. And it may not be surprising that a lot of these folks will have impaired gait and balance. So I'd like to move on to the evaluation of dizziness, and the history is critical. It's important to have the patient describe in their own words without much prompting as to how they would describe their condition. And then you want to ask them more about timing, what provokes it, and what will exacerbate it. And finally, to find out how these symptoms are affecting the individual's function and quality of life. So does it really take them out of action, or is it a mild nuisance? So you want to try to establish the range of functional disability that this is causing. So in terms of timing, looking at the history, you want to find out whether it's prolonged severe vertigo and versus recurrent spontaneous attacks or chronic persistent. So if you can get a sense of the timing between these three possibilities, the prolonged severe vertigo would be more suggestive of vestibular neuritis or stroke, things such as migraine headaches that are associated with vertigo or presents solely as vertigo as opposed to head pain. And then the recurrent spontaneous attacks would be more Meniere's disease or also migraine. And then the persistent or chronic dizziness would be more associated with psychogenic problems and possibly cerebellar disorders, so cerebellar atrophy, tumor, and so forth. The other part of the evaluation is to find out what provokes the dizziness. So spontaneous is, as stated, occurs without any known causes. Some people say I rolled over on the right side of my bed and the right side of my head, and I started getting dizzy. And every time I do that, I get dizzy. So that's positional. And then also individuals that say, oh, I get up out of bed and I have to sit for a while before I stand up because I feel lightheaded. So that would be a postural associated condition. So here we have the third element that we want to ask about is whether aggravating factors such as understanding that if head movement causes the vertigo to be worse, then it's more likely to be vestibular oriented condition. So some of the key features of evaluating dizziness include orthostatic blood pressure and heart rate. Just want to caution you that if somebody is on a beta blockade, their heart rate's not going to change a whole lot from the supine to upright position. You want to do provocative maneuvers and watch the eyes for nystagmus. I simply just do a cross-check initially of having the individual follow my finger in pursuit, because sometimes you can see changes in saccadic rhythms as well as beating nystagmus, which clearly if you bring the eyes to the fullest extent laterally, there is physiologic nystagmus, so that doesn't count. But if you start getting nystagmus with a 30 degree rotation of the eyes, or if you see, and we'll see a video of rotatory nystagmus, those are always pathologic. You want to check both ears for fluid, certainly cerumen impaction also. In terms of cardiovascular, you want to auscultate for bruits. It's important to listen for aortic stenosis murmur. I also like to include a shoulder shrug and cogwheel test. The shoulder shrug, if weak or central weakness, often may represent conditions that can cause central muscle weakness, such as metabolic disorders with hyper or hypocalcemia, as well as polymyalgia rheumatica as some key examples. And then finally, it's important to observe for balance and gait difficulties. So we like to do the Sharpen-Romberg, where if you put one foot in front of the other and see if the individual can hold that for at least 10 seconds. And other maneuvers, such as the timed up and go test. So some of the provocative tests for the vestibular system are listed here. In the picture here, this is the sideline test where the individual has their head turned, and it's somewhat like a Dix-Hall-Pike maneuver, where you're trying to get different angles on the semicircular canals, that are vertical, horizontal. So let's see if we can get this video to work.
And now the eyes are beating to the left. And do you have a little dizziness there?
Yes.
Okay, let's just see how long that lasts. That's what we expect when there are crystals in the horizontal canal.
It took a while for it to do that.
Okay, I'm going to turn your head to the right now. And on the right, we have some dizziness. That's quite strong. And to the right. Did it feel stronger to you?
Yes.
Okay. All right, I'm going to turn your head all the way.
So that was a good example of where rotation of the head to the right had a little stronger induction of nystagmus, and you notice that it was beating medially rather than laterally in this particular maneuver. So let's see if we can get to the next slide here. Okay, so this is an example of rotatory nystagmus. This actually made me dizzy watching this. Good gracious. So this is really an exaggerated form of rotatory nystagmus. They're often more subtle than that and are picked up on video nystagmography. So the Dix-Hall-Pike test is as described there. You have the individual sit in the clinical table. You turn their head to either the right shoulder or to the left shoulder, and then you guide them down. Don't let them flop down to the have their head dangle lower than the table itself. Now this maneuver is really hard to do in older adults because a lot of them have cervical arthritis, cervical neck arthritis, and I always find it very difficult to get them to lower their head below the horizontal of the clinic table. But nonetheless, this is the procedure that you need to do for Dix-Hall-Pike maneuver. Some of the other tests that we need to consider are to look for anemia, calcium and electrolyte disorders, both vitamin B12 and folate deficiencies, particularly folate in the diabetic patient, as well as thyroid disease. So hypothyroidism is often associated with both hearing loss and with vestibular disorders. You might want to consider audiometry, particularly to help you look at cochlear symptoms such as tinnitus or asymmetric hearing loss, and it may help differentiate between acoustic neuroma and Meniere's disease. This is a picture of goggles worn by an older adult where different provocative images are provided to allow the eyes to track with this procedure called video nystagmography. I myself had performed video nystagmography in our geriatric clinic quite successfully. We used it both for diagnostics for central and peripheral neuropathies associated with vertigo, but we also used it for therapy because you can, again, whatever procedure that you do for the video nystagmography, which includes like cold and warm calorics, saccadic pursuit, and a number of other tests, that whatever tests produce the vertigo, you can then use those and replicate them in short recurrent bursts to help habituate the response. So I'm a big fan of video nystagmography, but it's not available at all clinics. Further diagnostic testing might include EKG. You want to look for certainly prolonged QT interval in people that may be on more than one SSRI. Holter and event monitors usually are not too productive, but can be considered. Tilt table testing could be used for individuals with true syncope. Quite honestly, I don't use tilt table testing or make that referral much at all in the older adults. And of course, if you're looking at acoustic neuromas, tumors, cerebellar disease, neuroimaging with either head CT or MRI would be appropriate, as well as looking for things like normal pressure hydrocephalus, which may not contribute directly to dizziness, but may give that sensation of either lightheadedness or wobbliness is probably more the description. So I found this kind of interesting. Just want to share this with you. This is another maneuver for habituation for otolith
I woke up in the
disease.
morning, everything started spinning, and it's this violent, the room goes like a spiral into space. You know, you feel like you're flying off the bed. I knew immediately what it was because this is my job. So we have the cochlea, the hearing part of the ear, and then we have the semicircular canals, the spinning sensors. So what happens is the particles that are in the utricle can sometimes get into this opening. When you lie down in bed at night, the particles can just fall in by gravity. And then when you sit up in the morning, they get all the way down here to the bottom of the ear. But when the particles build up to a big enough clump that they form a piston in the canal, then when you move your head like this, the particles move a sensor in this structure, and you feel that is spinning. And I knew that the particles were here, located in this ring. And so I had to figure out how to get them out. So I made a little model with my hands like this, and I twisted and turned it, figuring out a new way to do it. And I realized if I went forward, I could get the particles out. I made up the half somersault, did it, came up, and it was gone. So you start on your knees, and you tip your head straight up to look at the ceiling. And you hold that position for a few seconds. You'll usually feel a little bit of a spinning when you do that. That helps start the particles moving. Then you put your head completely upside down, tucking your chin a little bit so your head isn't perfectly vertical. It's actually tucked under slightly towards your knees. So during that time, you turn your head towards your right elbow if you're going to treat the right ear. If you're treating the left ear, you turn the head to face your left elbow. The side that you get the most dizzy when you're lying down and rolling over. So if you roll over to your right and that makes the spin, and you roll to your left and it goes away or it's not as bad, then you have it in your right ear. In that position, the particles will start to move and you will feel the spinning. You wait for all the spinning to stop, or you can count to 30 and then very quickly raise your head to back level. So your head and your back are on the same level, but you're keeping your head turned at that 45-degree angle. Then you again wait for the spinning to stop, 15 to 30 seconds, and then you bring your head fully upright so that you end up kneeling again. And in that position, the particles should leave the ear. But sometimes it takes 4 or 5 repetitions. The safest thing is to repeat it with 15-minute breaks between each attempt, because that allows the particles to fully settle out away from the opening. If you can't get rid of it, even after trying it repeatedly, you can always see a doctor and go in and have other maneuvers done.
So I think that's really a great example of habituation therapy for otolith disease. So let's get to the next slide. So in terms of management of vertigo, we want to look at benign positional vertigo. So there's the Epley maneuver, which is very similar to the Dix-Hall-Pike maneuver. But basically, occupational therapy or physical therapy can do vestibular rehab. So that would be the referral of choice. In terms of Meniere's disease, some suggestions are to have salt restriction, to use diuretics, and also to use a vestibular suppressant such as meclizine. In severe cases, you might consider a referral to the ENT service. for decompression therapy. They basically, it's a over pressure within the cochlea that needs to be relieved. And then in terms of medications that might be associated with vertigo, stopping if they're on chronic immunoglycosides, switching from diuretics to some other type of antihypertensive, and to discontinue the nonsteroidal anti-inflammatory medications. In terms of pre-syncope, the big issue there is to treat with hydration, particularly if there's orthostasis. One of the axioms in geriatrics is to avoid dual alpha and beta blockade. So if you had somebody on terazosin, minipress, plus a beta blocker, usually not a good combination. So particularly in men where the alpha blockade may be used, like Flomax, for prostatic hypertrophy, it may be better to put them on finasteride as an alternative, because they're both actually equal in their ability to reduce blockage in benign prostate hypertrophy. Other recommendations are to kind of tell the patient to take it slow, get it slowly up, rising from sitting or lying down, wait, maybe tap your feet a few times, and then to get going. Also, compression stockings are an important adjunctive therapy. Also, referral to physical and or occupational therapy. And then as a last resort, in cases such as Shy-Drager syndrome, you may end up using fludrocortisone or midodrine is indicated. In terms of postprandial hypotension, recommendation is to use small meals and to avoid excessive exertion after eating. And as we saw by the graph, it can last for a couple of hours after a meal. So it's important to keep that time zone in mind. In terms of disequilibrium, things or conditions that are associated with ischemia, it could be TIAs, for example. You want to use antiplatelet therapy. Also to recommend postural therapy or gait stability through physical therapy. If there's an acoustic neuroma, referral to ENT or neurosurgery would be useful. In terms of Parkinson's disease, appropriate medications and also rehab therapy. Also to point out that exercise in Parkinson's disease is better with bicycle therapy than with walking. For some reason, the pedaling is less problematic, in terms of gait and balance. In terms of peripheral neuropathies, I think that's pretty straightforward with either vitamin replacement or treatment of hypothyroidism. And in terms of cervical spondylosis, you can again go through rehab. Surgery is may be indicated, particularly for severe spinal stenosis, but my experience is that it doesn't always help in the long run. So to manage other forms of dizziness, we need to consider psychogenic etiologies. And so either psychotherapy or antidepressant therapy to deal with either depression. So SSRIs, you want to avoid the SSNRs. You don't like to use the norepinephrine type or class of antidepressants. Those tend to have more side effects in the older adult. In terms of the management of mixed etiologies of dizziness, you want to look for medication issues, and you want to discontinue or give a trial of medications that you consider causing the dizziness. And then sometimes both cognitive behavioral training can be an important intervention, as well as medication management. So I just wanted to show Epley's maneuver, and this is the different positions. Like I say, it's basically have a position sitting up, and then lying down where you rotate your head. You're in the Sims position here, and then you have head rotations to the left and to the right. And this is usually good treatment for benign positional paroxysmal vertigo. So I want to talk a little bit about research. A recent study here from Italy using polyphenol mixtures. They call it vertagogol, if I pronounce that properly. And it's apparently in a small study of about 120 patients per control and intervention arm, they found that it reduced subjective sensations of vertigo or dizziness, but there was not objective findings when they did the provocative testing. Interestingly, a study from Europe called the Revert Vertigo Registry found that over 90% of the individuals that had vertigo improved over time. And I just want to mention that ginkgo has been used for treatment of vertigo, and I just didn't see a whole lot of evidence and to support it. But you may see folks taking that as a non-medical medicinal. So to summarize, the precise classification of dizziness into the concepts of true vertigo, pre-syncope, disequilibrium, and lightheadedness can be a challenge for the clinician. So that's why it's important to do a structured exam and get a good history. Most dizziness will resolve, and it can be habituated. So those are all the reassuring aspects in discussing the problem with the patient. And then always keep in mind that while you may do a good medication history, that half of the patients don't volunteer the fact that they're taking over-the-counter supplementals, or perhaps a spouse or a friend or another family member's medication or supplemental. So it's always important to really do a deep dive in the questioning about their medication use. Some of the key physical exams include mandatory check for orthostatic hypotension, and performing different provocative tests like the Dix-Hall-Pike maneuver, as well as observing gait. And the fundamental treatment of dizziness needs to focus on the underlying etiology or disorder. So that's the end of this presentation. Appreciate your attention, and look forward to having you view some of the other presentations that we have on principles of geriatrics. Thank you.